This film is about early protected movement for K-wired finger fractures with pain-guided hand therapy. This man had 3 finger fractures with scissoring of the 2 ulnar digits and an intra-articular fracture of the long finger. We will show you how we K-wired him and moved him after surgery in order to get a good outcome. We used the wide-awake approach to K-wire the finger fractures. We injected 20 cc's of 1% lidocaine with 1 in 100,000 epinephrine. The film is increased in speed greatly in order to make it more efficient for you, but it was injected very slowly to decrease the pain. The proximal phalanx fractures of the 4th and 5th finger were then K-wired, and the fingers moved with the patient without a tourniquet, without sedation, so that we could see how stable our K-wire fixation was. We are interested in getting functionally stable fixation, not rigid fixation. Functionally stable fixation is enough fixation that the fractures will heal in a good position of function. We never open fractures that we can treat closed because of the prolonged scarring caused by blood that gets all through the tendons and the bone and sticks everything together. We put in as many K-wires as required so that the patient can do early protected movement after the surgery in order to get a good result. Here he is at the end of the case saying that he didn't mind it at all because the local anesthetic was quite sufficient and he was pain-free. I tell him that he has to keep his hand up higher than his heart just like this, and that the hand is on strike over the weekend. He comes back on Monday morning with very little swelling and pain because he followed our advice. He is now completely off painkillers, and our hand therapist is instructing him how to just keep the joints moving a little bit. We just don't want the tendons to get stuck. His pain tells him what he can do and what he can't do. We tell him that he can't move it if he is on any kind of painkiller, including acetaminophen or ibuprofen. He's allowed to move it, but he can't use it. We build him splints just like for flexor tendon injury post-operative management for early protected movement. And he removes the splint 10 times a day, stabilizing his fracture and keeping the finger, DIP, and PIP joints moving just enough so that he doesn't get stuck and so it doesn't hurt. We removed his K-wires at 2 weeks when the fractures were no longer painful to palpation, and here he is at 3 weeks after surgery with almost a full range of motion. Early protected movement is as important in finger fractures as it is in flexor tendon injuries. With flexor tendon injuries, we're willing to do early protected movement at 3 days post-op, even with a risk of tendon rupture. We do that because a stiff finger is a useless finger. If we immobilize finger fractures too long, they're going to be stiff as well. We only need to have the finger moving a little bit in order for the tendons not to get stuck and stiff. The worst that will happen is that we may lose a little bit of our perfect reduction and ruin our perfect, beautiful post-operative X-ray a little bit. However, we don't need absolutely perfect anatomical reduction for non-articular finger fractures. As long as we have a full range of motion and no scissoring at the end of treatment, we have a successful outcome. If we do lose the reduction with early movement to the point where we need to re-reduce the fracture, that's still going to be easier than redoing a flexor tendon repair. Just as we do for our flexor tendon repairs, we don't move our finger fractures immediately. Collagen formation doesn't even start until day 3. If you move them the day of surgery or the day after surgery, you're just going to bleed into the wound and the blood will turn to scar and get everything stuck. If they keep the hand elevated, the swelling comes down, there's no bleeding into the wound, and their likelihood of getting a better result is increased. Over the years, I have frequently seen situations where radiologists say that the bones are not healed, and yet when I operate on those fingers, there's concrete in there where the callus has made everything stuck. The important point is that when the fingers are no longer tender to palpation, it is the time that you can take out the K-wires, because you know that there's enough healing inside that the fractures will no longer move with gentle movement in an early protected movement regime. Good advice for patients is that there are two kinds of pain after any broken bone or any operation. The first pain is the pain of the cut or break, and that's pretty much gone by 2 or 3 days. And it's okay to take pain medicine for that, but if you keep your hand elevated and don't move it at all until you're off all pain medicine, then you're going to get better much faster. Once the pain of the cut or break is gone, you get into the pain of, "Gee, doctor, now it only hurts when I move." For the pain of, "Gee, doctor, now it only hurts when I move," quit taking painkillers and don't move. Listen to your body. It will tell you what to do and what not to do. We didn't spend 2 billion years evolving pain because it's bad for us. It's nature's only way for our bodies to tell us, "Stop that, I'm trying to heal in here and you're messing it up." Reasonable patients will understand this easily. Early protected movement is not for everyone. You need a good patient just like you do for early protected movement for flexor tendon repair. My best advice to residents is never open a fracture that you can treat closed with K-wires. The surgical space fills with blood which turns to callus and scar. If you don't open that space, you have fewer problems. In summary, early controlled movement in finger fractures is as important as early controlled movement in flexor tendon injuries. Never open a fracture that you can treat closed. Your pain is your friend. Get off pain medicine as soon as possible and listen to your body. Don't baby it, but don't do what hurts. Let your pain tell you what you can do and what you can't do to guide hand therapy.